Welcome to our news edition of What's Your Focus. Today, I would like to talk to you about our current issue in non-muscle invasive bladder cancer. And our guest editor is Dr. Max Cates from Baltimore. Welcome, Max.
Thank you. It's great to be here.
Dr. Max Cates is an associate professor of urology and oncology in the Brady Urological Institute. He also directs the Division of Urologic Oncology for the Brady Urological Institute. Max, I'm sure most of the audience knows you, but maybe you want to say one or two words about yourself, what your special interests are, especially in the field of urologic oncology.
Sure. Yes, my interests are really in the bench to bedside discovery in bladder cancer. I have a particular interest in non-muscle invasive bladder cancer, both in the laboratory and in the clinical trial.
Very nice. Now, thank you very much for working with us and to put together that really good issue on that topic. In your editorial, you write less is more. Can you explain to us why you wrote that?
Sure. So, if we look at the last 100 years of surgery, really, we started with Halsted, where we didn't know much, right? And so we removed as much as possible to cure cancer. And over time, we've learned to do less and less in a very thoughtful way. And so here we have non-muscle invasive bladder cancer, which is currently in our current paradigm, sometimes treated with removal of the bladder and the prostate, or in a woman, the bladder and the vagina and the uterus. Or more oftentimes is treated with many rounds of different therapies and many rounds of TURBTs. And it's a very intensive treatment for this disease. And so my point in that editorial was really to state that as we're learning more about this disease and as we're creating better and better therapies, that will allow us to improve our patients' quality of life by pulling back in terms of how aggressive we are with our therapies.
And maybe in that very same direction, you had that interesting debate initiated where you talk about restaging and the value of restaging for high-risk cancer. Can you just maybe in one or two sentences wrap up what that debate is about? Maybe your point of view. It's hard in a short time, but just for a gist,
No, I think that's a great example of this less is more sort of paradigm, which is we're right at the tension point with whether a restaging TURBT is necessary. On the one hand, those that would favor it for long-term cancer control, we know that complete eradication of the disease in the bladder is the most important thing for patients to avoid a cancer recurrence and to have a good outcome. Yet, we also know that these TURBTs do come at a cost for our patients with urinary frequency and urgency and long-term issues with their bladder compliance. And so the debate is really, and we have better techniques. And so increasingly, we're finding on these restaging TURBTs that there's oftentimes less cancer present or no cancer present, given the high quality of TURBTs that many are doing. So where I fall on that is, in my patients, it's really a balance. If I have a patient who is, frail or older with already poor bladder compliance, and maybe not a great person to receive anesthesia, I'm really going to view this as the first time I do that TURBT is going to be really, I'm going to try to make it the last time. But if it's a young and healthy person and there's no contraindications doing anesthesia, then I will typically follow what are still in at least the AUA guidelines and many of the guidelines, which is doing a restaging TURBT. So this is where medicine is oftentimes an art in combination with a science.
So it's really about also individualized treatment. And I think you mentioned one aspect which I find really important is the frail patients, because I think we don't put enough emphasis on the frail patients, where oftentimes I find that the guidelines don't really fit. So I like that example very much. Can I follow on this path? Because there's one article that sums up active surveillance and the role of active surveillance in bladder cancer. Can you say something about that?
Yes, I think this is yet another example of what I mean by less is more. So we're really learning that, especially in patients with low-grade non-invasive cancers, in certain situations, it's absolutely appropriate and maybe indicated to follow these tumors without any interventions, particularly without general anesthesia. To your point about frail and older patients, sometimes, very much, many of the times, less is more. And what we mean by that is monitoring growth of these tumors that we know to be low grade and non-invasive is sometimes preferable than putting them under anesthesia and resecting a tumor and giving that patient that increased risk of a complication from either the surgery itself or the anesthesia.
Very nice, thank you. Maybe one more comment. We can't go into detail with regard to all the papers because there are many, and I really encourage all the readers and our auditorium here to really read that issue. But there's one article that talks about BCG and biomarkers for BCG response. Any new ideas here?
Yes, this is an area where if you're going to do an issue around non-muscle invasive bladder cancer and what's new in the last, especially 5 years, really at the forefront is going to be developments in trying to predict response to BCG. And I think the authors of that article were careful to explain that we don't have all the answers yet, but there's an incredible amount of work being done looking at innate and adaptive immune response to BCG. Both are probably implicated. And there's also an incredible amount of work being currently done on looking at both urine and tissue-based biomarkers to try to predict response. So the answers are not there yet. It's still an ongoing project, but there's been a lot of great developments.
Thanks a lot, Max. Just maybe one more question, and that's my typical last question for a guest editor, which is, what do you think is the next big thing in that specific area? What do you think is going to come in the next 3 to 5 years, which we can anticipate coming?
Yeah, so the paradigm of non-muscle invasive bladder cancer is going to have an immense shift in the next 3 to 5 years. And it's going to be akin to before we had good drugs for metastatic prostate cancer. We really had ADT, right? And then all of a sudden we saw 5 to 10 years where 1 year after another, we had a new approval of a new drug. And we're seeing that exact same thing. We're in the middle of it right now for non-muscle invasive bladder cancer. And so the challenge for us is going to be when we have a menu of 5 to 7 drugs, how do we sequence them? How do we prioritize them? How do we think about cost? How do we predict response to each one of these new drugs? So that is really where we're at with non-muscle invasive bladder cancer.
Really exciting. Thank you very much. Thanks again for working with us. I look forward to seeing you very soon, and it was great to work with you on this issue. Congratulations. Thank you.
Thank you.